My name is Dr. Edward Ngwenya, and we continue with our plastic surgery podcast series. This today we'll be discussing under the trunk, series. We'll be discussing pressure ulcers, and going through that. What are pressure ulcers? How do we define a pressure ulcer? What are the etiological factors of the causes thereof? And how do we then classify a pressure ulcer? And after classifying a pressure ulcer, we've got a patient coming in with a pressure ulcer. What are our considerations? How are we going to physically manage this patient, non-surgically and then surgically? And of course, what are our reconstructive options, the pros, the cons thereof? So this will be briefly just touching on the subject of pressure ulcers. So without further ado, let's go into the pressure ulcers. So what is a pressure sore or a pressure ulcer? So I think we can define it as, a pressure ulcer being a localized injury to the skin and or underlying tissue, usually over a bony prominence as a result of pressure or pressure in combination with shear. So it's a localized injury to the skin and or underlying tissue. Usually it's over a bony prominence, and it's as a result of pressure or a combination of pressure and shear. And so you would then understand that in dealing with pressure ulcers, the microenvironment, or rather the microclimate, which is moisture and pressure, also would play a significant role in contributing to pressure ulcers over and above just pressure and shear. But certainly the moisture, the temperature, the microclimate is something that plays a significant role. We'll discuss that further. So generally, this is something you're going to see a lot. If you're a plastic surgeon, you will get consulted for pressure ulcers. In fact, when we look at South Africa, the country where I reside, if you look at the lawsuits or the litigations that came over the last year, you will see that predominantly the majority actually came from pressure ulcers. A patient goes to hospital, they were fine, everything was okay, they had a head injury or whatever other reason that they had a chronic illness, and they come out of the hospital with a pressure ulcer. And of course, you can imagine this is something that can be problematic to a patient who was okay, and now the back of the head or the sacral region or the ischial trochanteric, whichever, the heels are necrotic and have ischemic tissue therein. So generally, it is something common. In fact, pressure ulcers develop, if you look at the incidence, it ranges anywhere between 3 to 14% of hospitalized patients. In fact, if you look at it, it's actually associated with 5 times increased mortality in the elderly. So this is something to take quite seriously, because a third of these patients will actually die in hospital. So the incident is extremely high, specifically in the elderly patient who come in with, the neck or femur fractures, or quadriplegic patients. Generally, you'd get the incident being quite high therein, as high as 60%. We also see it in, neurological impaired patients, specifically the very young. You'd get, patients who have cerebral palsy, or, spinal cord injury patients who would present with this, and the incidence we see it quite significantly higher. And as I explained, in chronically hospitalized patients or palliative care, we see this to be quite a lot. What's of interest, if you look at at it in, spinal cord injury patients. Generally, we find that when they come in on the early phase, you would find those, ulcers in the sacral regions. The sacral area actually tends to be the most common site of the pressure ulcers. And then when we go then to the subacute and chronic phase after spinal cord injury, and you may find in patients who are ambulating on their wheelchairs, or who are now in a sitting position, the ischial area becomes more predominant. So you must just have an understanding on generally how are you going to, where would you find sacral ulcers more commonly in, patients in ICU perhaps, where are you going to find ischial ulcers in, and you should be able to at least have a grasp of saying, generally spinal cord patients would have predominantly either sacral or ischial. You should be able to know which are those, as we've explained. The mortality, as I've explained, is quite high. But when we look at data, it does not necessarily lead to a conclusion that a pressure ulcer in itself is directly responsible as the cause for increased mortality, but rather we see these patients succumb to their overall disease burden, which in itself leads to other things being problems such as malnutrition, immobility, decreased tissue perfusion, and these generally will allow for pressure sores to then form. But something, as I've mentioned, that costs the health industry a significant amount of money. I think it was 1 million per patient or 100,000 per patient to treat and heal ulcers that are acquired in hospital. So that's quite significant. So, which are the susceptible areas we've mentioned? Predominantly 28% it would occur in the ischial tuberosity. Of course, the bony prominences play a significant role. So generally, if you look at it overall, it's the ischial tuberosity, 28%, then trochanteric ulcers, 19%, sacral coming at 17%, the heel at 9%, and the scalp then being the last. However, we know the distribution may vary depending on the sample size and the patient that you are actually looking at. But certainly, I will repeat mentioning this is something that is imperative, because the complications of just simple paraplegia are significant. I mean, we speak of not just ulcers, but chronic UTIs. We speak of demineralization of bones, malnutrition, mental depression, amyloidosis being another, cause that can happen, amyloid proteins from bones that are distributed to other organs and may lead to organ failure, calcification of soft tissue, even death. These are the serious complications in a patient who's paraplegic. So, something to take seriously. Now, I think let's discuss the etiological causes, or rather, the etiology of sacral bed ulcers. And the way we can look at sacral or pressure ulcers, rather, broadly speaking, not specifically sacral, but pressure ulcers, they are caused by two main factors. We can divide it as extrinsic factors and then intrinsic factors. Now, when we look at extrinsic factors, we can divide it into two: either mechanical force on soft tissue or issues related to moisture, the microclimate they're in. So, extrinsic factors are mechanical force and then moisture. Moisture we can quickly touch on. Moisture usually leads to skin maceration, would lead to skin maceration and breakdown, and most often you would find that it's usually in patients who have incontinence, and so we will speak about the management thereof when we come into how to address these factors. So moisture is certainly a cause that can lead to skin maceration and breakdown. Whereas in mechanical forces, we can divide into three mechanical causes. Number one, friction. Now, remember, friction, we define it as resistance to movement between two surfaces. So, these you would actually see it affecting the outermost skin layer. That will be the part that is lost. And once you lose the outer layer, the epidermal layer, it results in increased water loss. So you can see that you then go into this complicated vicious cycle that you then enter, because you have these surfaces as a patient is being transported, or a patient is being changed perhaps. You may then have a friction then occurring. Shear is another cause. Now, shear is, what can I say? It's mechanical stress parallel to a plane. So stretch, things like stretchers, or rather, let's explain it in a way that usually what would then happen, or what causes this ischemic necrosis to the skin, is as you get this shear force, the stress on this parallel plane, you then get stretching or compression of muscular perforators, and as they stretch, they then will then lead to injury therein, and results in ischemic necrosis that you will find there. And so pressure is another one that you may consider. Friction, shear, and then pressure is the other element. And this we can define as mechanical force per unit area perpendicular to a plane, as opposed to shear, which is parallel to a plane. This is perpendicular. So this is something coming from underneath. It leads to tissue deformation, mechanical damage. It leads to blockage of vessels. And so then you will find necrosis. But where does this necrosis first happen? Secondary to pressure over this bony prominence. You actually first find it in the tissues closest to the bone, usually being the muscles there. And so what you then see is just a tip of the iceberg from the top. In fact, if you look at several studies, such as one that was done by Landis in the 1930s, he found that if the external compression force exceeds a capillary bed pressure of 32 millimeter mercury, then you will have that. But it's not just the pressure alone, as we found, but capillary perfusion is impaired, and ischemia will ensue, not only with pressure, but the amount or the duration of time exposed to the pressure. And this will become interesting as we then, manage it directly, the pressure-related causes, it targeted at actually understanding the physiology, that the amount of pressure greater than 32 millimeter mercury, but also the duration plays a role. And we found certainly that pressures of 2 times capillary arterial pressure for 2 hours actually produces irreversible ischemia in animal models. So when you are supine, maximum pressure, which is about 40 to 60 millimeter mercury, are usually at the heels, the buttock, and the sacrum. Whereas when you sit, the pressure then gets distributed more to the ischial tuberosities. So just understanding that general physics will help you understand how we can manage then these patients. So these are our external mechanical forces, which are the mechanical forces and the moisture. Now, what are the intrinsic factors that cause pressure ulcers? I like to divide these as patient factors on soft tissue from a systemic side and from the local side. Let's start locally. So locally, Ischemia or fibrosis, as we've mentioned, is what's going to cause this decreased tissue perfusion and what will actually predispose one to necrosis. So the pressure areas is something to consider. Infection is another intrinsic factor, and usually your Staph aureus, but even your things like your Proteus, mirabilis, even E. coli, Pseudomonas, these are other factors that may contribute. Decreased sensation is a big one, of course. If you are unable to experience discomfort or pain from prolonged sitting or any other position, this will lead to tissue ischemia. Other things are joint contractures, spasticity, as we've mentioned, such as you may get in children with cerebral palsy. Example, these are some of the local intrinsic factors that will cause pressure ulcers or will contribute as a cumulative effect to one developing pressure ulcers. What are some of the systemic factors we should look at? Elderly patients, old age, very important one, because of course they've got decreased skin moisture. They may have decrease in tensile strength, increase friability therein. So something to certainly, when you see an elderly patient, you need to be on your guard. Immobility, big one. Acute illness or terminal illness is something else. Altered level of consciousness, because you lose your protective reflexes or voluntary, movement to offload any pressures. Nutrition is a big one. So impaired nutrition or hydration, if you have a low lean body mass, anemic, decreased ability to heal, as you know, regarding wound healing, what nutrition has a big role therein. And just deficiency in specific vitamins are some of the causes. Anemia, as I've mentioned, is a big one because that causes decreased wound healing capability, and it weakens and may actually lead to prolonged immobilization. So anemia is one of the systemic causes. And last but not least, comorbidities. You got to think of things that will impair perfusion, such as diabetes, smoking, peripheral vascular disease, or if we are using vasopressors, and you've certainly have seen, patients who are in ICU, who are in shock, and they are on higher inotropes, and vasopressors may get quite ischemic because of the effects on the capillaries and therefore perfusion. So I think the big thing, once we are able to then distinguish and define our etiological causes or the etiology therein, it's important to be able to classify a pressure ulcer. And generally, we use the National Pressure Ulcer Advisory Panel stages, which are stage 1 to stage 5. Therein, there's also a part which is unstageable, and then a part where we suspect a deep actually ulcer therein. So what is stage 1? I like to compare it to burns, or to the anatomy of the skin. It becomes easy when one sees it because stage 1, it's usually just that erythema that you will get, this non-blanchable erythema of intact skin. So the skin is intact, but there's that erythema. That's a stage 1 ulcer as per the NPU AAPCS, the National Pressure Ulcer Advisory Panel stages. Stage 2, then, as you would have, with burns, is your partial thickness skin loss. And this usually presents clinically as blisters, abrasions, or just a shallow open ulcer. And just 2 to 6 hours of pressure is going to give this. And this erythema generally will last for more than 36 hours. So this is partial thickness skin loss. Now, when we go to stage 3, we are on full thickness, tissue loss. However, it does not transverse or does not go through the fascia. So the fascia is intact. So in this, of course, you would have your subcutaneous fat that may be exposed, and you may have, tunneling that may start to develop. So stage 3, quite a difficult ulcer now. It's getting quite worse, but it's full thickness, but it does not penetrate. And then stage 4, of course, it's the full thickness or tissue loss. The depth generally, has gone all the way. However, in this, it involves the underlying structures below the fascial layer, meaning the muscles, the bones, tendons, ligaments, cartilage. It may even be the joint capsule. So this is quite a deep ulcer. Stage 1, erythema. Stage 2, partial thickness. Stage 3, full thickness, but does not go through fascia. Stage 4, full thickness, goes through the fascia. But now you may have a patient that you assess in the ward, and then you see this patient. However, you cannot assess the depth. You cannot really stage them because this ulcer is obscured by, there may be an usher that's formed, or there may be slough that's overlying the wound. So these we will group as unstageable, because we suspect it's definitely a full thickness. However, the depth is unknown because of those confounding elements. And then there are those that the ulcer, they have this purple area of intact skin. Remember what I mentioned regarding pressure, that pressure generally may be from the deep layer and actually affecting over the bony prominences, and the tissues that are affected are the ones that lie closest to there. So you may see a patient where you actually suspect deep tissue injury of unknown depth. So these ones, we also group them specially as suspected deep tissue injury, even though they just have that purple area, which may then be actually just a tip of the iceberg. I think now, understanding this, we can now go into the management of the patient. So, in other words, here's a patient who comes in. We have a patient who then comes, or you are consulted for this patient. How are you going to manage this patient in the ward? Remember, any patient that we then see, the first thing, and most wards and hospitals usually have this, these protocols of how to prevent skin ulcers. So the first thing will be, how do we prevent skin ulcers? So preventative measures are important. And generally, when you answer a question regarding pressure ulcers, you must first speak about preventative measures. And when you talk about preventative measures, we then will talk about our risk assessment scores that we can then use. And there are many risk assessment scores. There's the Waterloo, there's the Braden, there's the Norton. But what we generally use in our institution is the Waterloo classification. So it might help you just to have a look at those. Whichever you use, just know one. Whatever it is, know one and be able to, explain it properly when confronted, in an exam. And these are certainly just, basically interdisciplinary assessments that define or that assess or that determine an individual's risk of developing a pressure ulcer. So the one that I like, which is the Waterloo score, looks at 10 elements, these being the build or the weight for the patient. For the high, so we look at the BMI. Is this patient, obese, below average, above average, etc.? And then you'll give them a score depending on that from 0 to 3. And then we look at the skin type, We then look at the skin, the visual risk areas. Is it healthy? Is it paper thin? Is it edematous, discoloration there? Are there spots? And we'll give them a score from 0 to 3. Then the sex and the age of a patient, are they male or are they female? That being the sex. If they are male, they get 1 score. If they're female, 2. And then you look, of course, at the sex from, the age from 14 to 49, 50 to 64, etc., all the way until they are 81 plus, and you'll give them a score. Their appetite is important. How's their appetite? Is it average? Is it poor? Are they on an NG tube, or are they on fluids only? You look at that, you give them a score. What's their mobility? Are they fully mobile? Are they restless? Are they apathetic? Are they actually restricted? Or, this person is inert, and really bed bound or chair bound. They get a score, a high score of 5. Other things to look at is continence. Remember, we spoke about that. Do they have complete continence? Do they have a catheter, or are they incontinent? Is it fecal incontinence? That will also add to a score from 0 to 3. And then we look at special risks. Things such as tissue malnutrition. These are patients who've either got cardiac failure, anemia, smoking. You give them a score, or they are just terminally cachexics. Neurological deficits, very important to assess, and you give them a score between 4 to 6. And do they have major trauma? Other major trauma such as, or major surgery such as orthopedic or below the waist. You assess and you give them a score of 5. And then are they on any medication such as steroids, high dose or anti-inflammatories? These, of course, will affect their wound healing, and there they would get a score. So you use a score, it will assist you as a preventative measure. But now I would like us to then look into how we're going to manage this patient. Now, I like to divide it into groups. Have a structure, have a system that you will use. The system I propose is to look at the extrinsic factors. Remember, we spoke about extrinsic factors, the mechanical and the moisture. So how do you address extrinsic factors? How do you address intrinsic factors? And then how do you assess the defect? And then this will help you also all the way leading up to your surgery on as per flap options. So let's start with our extrinsic factors. There's the mechanical factors. So looking at friction, we want to take care whenever we are changing the bed linen, wherever we are transferring the patient, we must always aim to lift and not push the patient, because that's where they get these frictional injuries. Here, of course, as we've mentioned, we want to minimize, especially you'll get neurological patients, patients with head injuries. The neurosurgeon may say, put the bed at 45-degree head up. And generally, you just need to look at that with caution, because what we want to do also, we found that we need to minimize the head of bed elevation so as to reduce the sacral shear and pressure. So we would like that to be less than 45 degrees. So, of course, you manage the patient in a multidisciplinary team, and you just use these measures to then assist in collaboration with the other treating physician. Pressure, how do we address pressure? Well, there's the, Kozak's principles, which are pressure relief behavior. So in a patient who's seated, what we want to do, we want the patient to train them that they must be lifted or lift themselves up for 10 seconds every 10 minutes. Others, I have said every 30 minutes. But generally, every 10 to 30 minutes, the patient must lift themselves up on the wheelchair, and you train them, and then they sit down. If they are supine, they must be turned every 2 hours. So we'll want 2 hourly turning. So there, you need to, canvas and, galvanize your staff, your nurses that are there, because nursing care is imperative for these patients. We also want to support the surfaces wherein the patient would lie in order to address the pressure element. So would like our foam dressing on pressure points. We know if we can get at least 4 inches static pads, or as commonly what we used to use, as simple as sheepskin, were some of the things that we used as, dressings on pressure areas. And then, of course, you'll read a lot about special beds, SL mattress, fluidized beds. And you look at those, look at some of the studies, but generally, if you can get a good, mattress for a patient. And now we then need to, once we've addressed the mechanical issues, we then must address the moisture issues. And so moisture, we look at it, we want, if we've got a patient who's got maybe a sacral ulcer or who's unable to walk, we would want a diverting colostomy for that patient. And then what we want to then do is, instead of running and doing a Brickers or a wireless, and ostomy for a patient, we would rather initially start by intermittent catheterization. So I think that's better than a full indwelling catheter that you'll put there. You minimize infection, but also you assist, you train the patient, because they can learn than having the bladder, which, by the way, that detrusor muscle, you don't want it to collapse completely, stay collapsed for so long that it no longer, fills up and becomes a problem. So intermittent catheterization has worked well for us. And just general skincare. Use pH balanced cleansers, petroleum jelly, anything just to make sure the skin doesn't remain dry and it's well moist and taken care of. So these are the extrinsic factors we are going to look at. We are addressing a patient holistically. Then we look at the intrinsic factors, and I like to call these the patient factors. So when we look at patient factors, we must look at nutrition and supplementation. Herein, we are going to involve a dietitian. We work as a multidisciplinary group. And so for spinal patients, we know they are in a catabolic state. Therefore, they are protein deficient, and we want them in a high protein diet. So before I take this patient to theater, I want to make sure on a nutritional side, they are well taken care of. I'm going to look at a high protein diet. 1.5 to 3 grams per kilogram per day generally is well. Vitamin A, vitamin C, zinc, calcium, iron, copper, those trace elements, very important that they are not deficient. And this just simply addresses wound healing. Albumin you can use as a marker, even though we know, albumin, that the half-life is about 20 days. So it may be, reflective of the last 2 to 3 months, but it's a good guide to use in our setting, looking at an albumin greater than 30 grams per liter or 2 grams per deciliter. In order before you can take these patients. Comorbidities, you want to get a handle of these. If they're diabetic, you want to make sure you have their sugars controlled. HbA1c, you look at that as a guide. Or if they're anemic, you want to make sure we have an HB greater than 10 before we can take this patient to theater, because they can bleed. Smoking, they must stop. We need to review the medication they are on, check if they are on, Plavix, Clexane, warfarin, all these things, and manage them accordingly, preoperatively. The physical strength of the patient, very, very important to include your physiotherapist. It doesn't help to go and put in a beautiful flap, but the patient's upper body strength is weak and they are paraplegic. They just lie on the flap and the flap dies. So physiotherapy, you want to get the physical strength, the upper body strength to be quite optimal. Psychologically, you really need an involved, a motivated patient. We found, as per, I think these are in in 1992, the PRS wrote that younger and more motivated, more socially stable patients actually have fewer recurrences. So you want to involve your psychologist because you want a motivated patient who knows that, look, this may be a long road that we are undertaking, but patience and motivation and positive attitude is of utmost imperative. And then the physiological reserve is very important. We don't operate on ulcers, we operate on patients. So you want to make sure you get an anesthetic consult. You want to make sure you involve your physician to make sure the patient is operable. So you assess the operability, whether you're going to do a chest x-ray, ECG, hematological screening, all of those you are going to then do to check the operability state of the patient. You will also want to address contractures because contractures are a big one. Involve your orthopedic surgeon because they may need, tendon releases. Some of these patients, spasticity is a big one as well. So in order to improve spasticity, you must also look, at certain other non-surgical factors such as, physiotherapy, which is the first step that we involve, and then also the medications that we can use. Baclofen is a big one. We usually use 5 milligrams TDS per os and gradually increase to 20 milligrams TDS, the maximum dose being 80 milligrams per day. And you can also give actually intrathecally. And then, other things like your dantrolene sodium have been used at a dose of 4 to 8 milligrams per kilogram per day in 3 divided doses. And diazepam, on a dose of 2 to 10 milligrams per os TDS, or you may also give QID. But baclofen, generally the one that would come on strong that is used. But physiotherapy being your first strength. Spasticity, it's important to get a hold on that because, once you do it, improves the patient's positioning, weight distribution, hygiene, and also it helps to prevent tension on the healing wound. So you want to make sure we get a hold of those. There are other invasive ways we may use, such as nerve blocks, epidural stimulators, baclofen pumps, but rhizotomies, whether, surgically or chemically with phenol, are some of the things. And we know what a rhizotomy is, where you interrupt, a certain spinal root levels. Then defect factors are important to have a look at. I think before you look at the flap, you want to look at the defect. You want to classify it as we've defined our classification system. And we want to get what is the size, the composition, the composite nature thereof, and the area. And all of these will then assist you when you now choose your flap. What I like to also make mention of is that you also want to make sure you exclude malignancy. So a biopsy will help you exclude malignancy, exclude osteomyelitis, optimize this patient's wound as per the time principle. Negative pressure wound therapy, very effective as a first line treatment for especially stage 3 ulcers and some stage 4 ulcers, and this may actually bridge a stage 4 ulcer all the way up until surgery. We found it to be very effective in pre-operatively and even post-operatively. Your goals, what are your goals? You want to make sure that you debride these patients, you debride, and you perform a bisektomy. Using methylene blue, it will assist you in the dissection there to be able to use it and be able to see where you are. You may also, of course, need to shave some bone off and remove the areas that are problematic. But debridement, bisektomy, when you are ready to operate, with the assistance of methylene blue, you do a bisektomy, and then once you are happy with your wound, now we can play in the area of flaps, surgical management, definitive management for these patients. And so, of course, There, we know when you choose a flap, you look at patient factors, you look at defect factors, you look at flap factors, what are the size that we need, and you also look at the donor site mobility therein. So your flap and donor site factors are important, but you may just want to, especially for paraplegic patients, just think twice of using, just muscle. They do atrophy, but look, you just need to understand what you then use, fasciocutaneous or muscle, what's the mobility to the patient. Okay, so I think we should have covered, I think this is covered fine. Perhaps what we can then just look at, and I'm not going to get into the details, are your flap options depending on what you have. And I'm only going to talk about sacral ulcer, pressure ulcers, and I'm going to talk about trochanteric. We'll speak about what should we have? Maybe ischial. Let's talk about ischial, but I'm not going to address the heel because we speak about heel reconstruction. When we speak about the lower limb, and then the occiput, we speak about, that when we speak about scalp recon. So I'm only going to focus in those areas, but I'm not going to dwell too much on it. It's for you to have a look at and be able to then do this. So let's have a look at that. So if we've got a sacral pressure sore, what are we going to use? What options do we have available? Our options are either local options, they are either perforator flaps, they are, fasciocutaneous, they are either muscle flaps, or we may then use even free flaps in this. But what are the local options available? We've got our inferiorly based gluteal rotational flap, which is something that you may do a rotational flap. Preferably, what I like to do all the time, I use most of the time a rotational flap for my sacral pressure ulcers. It works well. It's a fasciocutaneous flap. You make sure you get the fascia there and you rotate, you make it quite big. And you just need to know the principles of performing a rotational flap. And this is where most, residents actually, get a bit trapped, especially in examinations, when now we have to say, how do you draw a rotational flap? Important to just know, your overall arch on top as a 5 to 8x, and then below, your 3 to 5y, and then just know what else you can use, things like your back cuts, your Barrett's triangles, but be able to draw it if you are going to mention it, how you triangulate the defect. Are you actually even going to go over the midline, or are you going to minimize it, knowing the perforasomes and angiosome theories? So these are just some of the things you need to hold, but that's a good option. Another good fasciocutaneous option that is done by many friends that I know and colleagues is a VY advancement flap. I mean, on one side, if it's less than 8 or less than 7 centimeters, you can use just unilateral. If it's greater than that, then you can use a bilateral VY advancement. I always argue, look, maybe you may be burning your bridges, but no. There are those in their hands, it's perfect, and it works well. Generally, you must just know then how you raise it, how you design it, and then just know where your perforators are. And generally, in a VY advancement flap, your perforators are on the medial third of the flap. Look, there are other flaps such as your lumbar transposition flaps that you can do. A bilobed flap, people have also done large keystone flaps. Those are other, options that you can use on a fasciocutaneous basis. Then you can use perforator flaps. You can propeller other areas. You can use an S-gap. You can use, your perforator sparing rotational flaps. These are just some of the things that have been mentioned. Or you can then take muscles, whether it's unilateral or bilateral gluteus max myocutaneous flaps that you can do. Tensor fascial laters have been mentioned. Fillet flaps, free flaps are other options that you have. But I think with the local flaps, you should be able to deal with it. And what I would recommend, if you can know, your rotational flap or your VY advancement flap, you are good to handle a sacral pressure ulcer. How about now our what shall we look at? Maybe an ischial ulcer. So if we've got an ischial ulcer, what options do we have? And the options that we have, can be just an axial pattern gluteal thigh flap. Gluteal thigh flap, posterior gluteal thigh flap, based on the terminal branch of the inferior gluteal artery, works very well. I love it. It works well. Others can even raise it randomly, and that generally will get you out of trouble with a pressure ulcer. I routinely use a posterior thigh flap when actually fixing, doing a ischial ulcer. But there are others. It may be medially based, the posterior thigh flap, based on myocutaneous perforators from either the adductus magnus, muscle, or gracilis. It can be a VY hamstring advancement. You can do, posteriorly based gluteal rotational flaps. There are others who do eye gaps, tensor fascia lata, although this is more actually used for trochanteric defects. But in patients with, an ischial ulcer, maybe who have spinal cord injuries below L3, it may be good. Why? It brings sensibility, and sensitivity to that particular ischial area. So might be a good option. And of course, there are muscle flap. Gracilis has been mentioned. If it's less than 40, squared centimeters, something to look at, and fillet flaps. But generally, I would say, a posterior thigh flap will get you out of trouble in most of these cases. But the options are vast, and I give you all those options. And others you look at, others you take with a pinch of salt, and others you assess if they will reach or not reach. So then let's look at what have we not discussed? I think trochanteric pressure sores. What are the options that we have? Generally, the one that predominantly always comes, and I think you should know it before you jump and mention others, tensor fascia lata flap. That one works. A tensor fascia lata flap, depending how you raise it, know how you do it. Whether it's pedicled, and then you base it on its most distal level, above the patella. You should be able to explain how you raise it. Where do you mark? You mark a line, from ACEs to the lateral condyle of the tibia, and then you mark 3 centimeters posterior to it, because what you have marked, generally ACEs to lateral condyle, that line actually demarcates the anterior border of the muscle. So you just go slightly then back, and then you then go and do parallel incision. You expose the muscle. Where do we expect our perforator from the ACEs? Generally 6 to 12 centimeters below the ACEs. There you will expect, our branch of the lateral cutaneous femoral artery then coming out in that area. So you have a look there, and then you just raise it. So you can either raise it and, as I've mentioned, pedicle it, or rotate it rather, transpose it to that particular area as a transposition flap, or as I've also commonly done in other occasions, use it almost as actually just a VY advancement flap, if you may, or a rotational flap, if you may, because what you then do, the advantages that are there, is that when you look actually at the muscle is actually only limited to the top, and the most distal portion, it's actually just your fascia. So if you use it as a VY advancement, you are able to actually put the muscle where you want it to be as a defect. But either way, as I've mentioned, it works very well as long as you can describe. Even a posterior thigh flap I've used often in those areas, and that can work well. But I think before you throw, other things such as your pedicled ALT, where you can include the vastus lateralis, if you want bulk, your rectus femoris, your fillet flap. Before you go there, I think you should be able to really speak about a tensor fascial lata, because it's right within the area there. But certainly there are many other options. Okay, and I think that then addresses it. I think what's important then is you don't operate a patient and walk away. There's post-operative care. So when you take the patient post-op to the ward, you want to continue your preventative measures. Mechanical, we look at friction, shear, pressure. Remember, as we've mentioned, we want pressure relief bed for 3 to 6 weeks. It's shown good evidence that after surgery, 3 weeks of bed rest followed by gradual sitting, scheduled results actually improve the outcome as per CME article in 2014. So physiotherapy important, seat mapping, sitting protocols if you have them, addressing the moisture, the bowel regimen or osteotomy care, skin care, very important. But don't forget the intrinsic factors, locally wound care, culture specific or directed antibiotic with, if there's infection, and you may want to consult your infectious disease physicians. And just systemically, you want to educate, keep motivating this patient. Antispasmodics, nutrition, keep it optimized. And then active and passive range of motion is very important in other extremities which are also uninvolved. So these are important things to look at. What are the complications? Perhaps we can look at complications. They are acute, they are chronic. Acute, generally hematoma, infection, wound dehiscence, big one. So, when you raise your flap, you kind of want to make it bigger. You don't want to burn your bridges because you want to be able to advance at later time, because wound dehiscence is quite, common. But also, the chronicity, or rather the chronic complication recurrence is a big one. In fact, overall recurrence can be as high as 82%, all the way from 7 to 82%. If actually you look at there's a recent large meta-analysis which looked at 55 papers, and it showed that myocutaneous flap have an overall complication rate of 18% versus fasciocutaneous flap, which it's 11.7%. However, the recurrence rate was found to be less for myocutaneous, 8.9%, whereas 11.2% for fasciocutaneous flaps. Perforatous flaps, they also range high in complications, 19.6, but they have shown actually the lowest recurrence rate of 5.6%. Of course, make sure you want to look at these patients and make sure there's no malignant degeneration, because 0.5 of these patients we found actually they have had malignant degeneration. I think that should cover our entire scope of pressure ulcers. Important to know the etiology, very, very important, but not just etiology, because the etiology will help you in managing the patient. Know that you must use a multidisciplinary team. Look at preventative measures. So when you approach a patient, you look at them holistically, addressing those factors as per the etiology, and then you look at your flap options, but you do not operate on a patient who's not optimized. And also in operating this patient, you must know what are your options. What are your options for reconstruction? What are your reliable options? And at least know one or two and know them very well. And not try to, do unnecessarily things. I think as per O'Brien, who mentioned that use the simplest, flap possible. And that should handle our pressure ulcers. Thank you for your attention. Looking forward to seeing you next time. Bye-bye.